cytokines. Oh, sorry, something's been happening. Continue. We're being recorded. Things like cytokines, which moderate the inflammatory reaction. So what do they do in joints? They're pretty active, involve chondrocyte proliferation. Chondrocytes are the cells in the cartilage that help produce the cartilage. They increase production of type 2 collagen, which is the fibrillar structure, like the rebars, for example, in reinforced concrete. They improve cartilage integrity through production of lubricin and hyaluronic acid, increasing water content of the cartilage. They also promote mesenchymal stem cell survival and proliferation. These are the stem cells that are in the joints and help provide regenerative option. They also have a strong effect reducing inflammation and damage. Within muscles and tendons, they promote angiogenesis, which is formation of new blood vessels. Myoblast and fibroblast activation, these again are the cells involved in repair of these structures. Type 1 collagen, which is the principal collagen in these structures. Hyaluronic acid and stem cells again, and they help resolve the inflammatory process. Many of these musculoskeletal problems involve a chronic repair, inflammation, re-injury, which never actually resolves. So the platelets have chemicals that can help this process complete. I'm going to be taking a quick look at PRP applications, including arthritis, patellofibrosis, tendonitis, and acute muscle and ligament injury. Osteoarthritis, extremely common. Prevalence in 2009 was around 14%, and by 2036, it's going to be 1 in 4 people. Lifetime risk of arthritis in the knee, 45%, and for the hip, 25%. And it's becoming one of the most common causes of disability as our population ages. Obviously, non-surgical treatments include exercise, diet, weight loss, supplements, and bracing. Analgesics and anti-inflammatories have a limited role, but once you get into chronic persistent use, particularly the anti-inflammatories, you run into problems with aggravation of blood pressure, asthma, irritation of the kidneys, and irritation of the gastrointestinal tract. Activity modification, that's sort of basically reducing your activity and giving into the arthritis, but that's not really something that I see as too popular in the semi-population. As far as surgical options, arthroscopy, traditionally, this was a very popular option a few years ago, the keyhole washout surgery. But over the last few years, it's really fallen out of popularity as the results have generally shown to be very poor. There are a few indications such as mechanical problems, meniscal injury, where it can be useful, but in the majority of cases for general arthritis, it's really no better than other treatments, and in some cases much worse. And in fact, the government has stopped funding for it. Osteotomy is a major operation, realignment of a limb, for example, but is mainly used as an option in individuals a little too young for joint replacement. Obviously, joint replacement is something I do a lot of, and it's a very common procedure, but it has significant risks, significant downtime, and obviously there are issues. And once you've had a joint replacement, it's a bit of a life changer in terms of possibility for wearing out and alterations of activity level. So the problem is there are very few options between simple treatments like bracing and physiotherapy and major surgery. And I think that's where PRP really fills an important gap. So what are we trying to treat in arthritis? Well, we've got loss of articular cartilage integrity. We've got disorganization of the cells and the matrix with poor injury response. We've got release of damaging cytokines and enzymes, which cause further degradation, and an inflammatory response causing pain and swelling. Treatment-wise, in terms of symptoms, we want to help resolve pain, predominantly from the inflammation, stiffness and swelling from inflammation of the lining of the joint and production of extra fluid. And we want to, if possible, slow down further deterioration over time. And as we've seen, platelets really fill this role. They've got a lot of factors that address all these different issues, from cartilage protection, regeneration, stem cell survival, and importantly, inhibiting the cytokines and damaging enzymes that cause further deterioration. PRP for knee arthritis is probably the most researched area for PRP use, and is now considered a mainstream therapy, especially in the US, where most insurance companies will cover it. and it's certainly more effective than other injections like cortisone or hyaluronic acid. There is a great deal of research out there. Here are a few examples. 2016, PRP versus placebo, a nearly 80% improvement in the PRP patients with only 7% in the placebo. Comparing PRP to hyaluronic acid, a meta-analysis is something where they look at numerous studies across the research literature, analyze them all, and come up with a consensus. This one from 2019 found PRP injections were far more effective than HA at 6 and 12 months, as evaluated by functional and pain scores. This one from 2020 concluded that based on current evidence, PRP appears to be better at HA at achieving pain relief and self-reported functional improvement. Couple from this year, this one looked at 1 year, significantly better WOMAC, these are the functional scores, and better pain scores for PRP versus hyaluronic acid. And the results lasted up to a year. They tended to fade fairly quickly following hyaluronic acid. This one's interesting, a randomized study, PRP versus HA again, significantly better functional and pain scores as before. However, there was a significant decline in interleukin and TNF levels, and these are the inflammatory mediators that not only cause pain and swelling, but they also cause further degeneration in the joint. These lasted up to a year in PRP and were far more so than HA, which tended to wear off after a couple of months. There was also interestingly evidence of chondroprotection using MRI evidence. The PRP group only showed reduced levels of deterioration in the cartilage. So PRP for knee arthritis, we're looking at 80% of patients reporting about 80% improvement. It seems to be effective at slowing further degeneration. Risks and complications and downtime are obviously minimal. And it can be expected to last around 6 to 24 months with an average of about 12 months. PRP injection therapy treats symptoms and pathology. It's got strong research support, far more effective than cortisone or hyaluronic acid. There are some studies showing better results with 2 to 3 PRP injections. And you can see this is why, all these reasons are why it's become an important part of my practice. One thing to note though, if you've got severe arthritis-related deformity, marked destruction of the joint, instability, it's not going to help with that, and that may be something that we need to consider surgery for. Moving on to patellofemoral, I see an awful lot of this. This is anterior knee pain, patellofemoral syndrome, a rather poorly understood condition and really difficult to treat. The cartilage changes are similar to those in arthritis. In terms of treatment, we obviously start off with things like physiotherapy and bracing. Surgery, very unpredictable, really only about 50-50 results, and sometimes you can risk making the knee worse by weakening it. So although we see a lot of it, it can be a difficult problem to treat. And I think PRP's really filled a niche here for me in terms of treatment option. It does provide a biologic and regenerative option for the cartilage. Obviously, risks and downtime as opposed to things like surgery would be minimal, and the results look encouraging. This study shows improvement in pain over a period of a year in PRP patients. And this one looks at before and after, marked reduction in factors such as pain, stiffness and rigidity, and poor functional levels, with improvements that certainly are noted within the first 6 months after PRP. Tendinitis, tendinopathy, another very common condition, lots of conditions, tennis elbow, Achilles tendinitis, patellar tendinitis, rotator cuff problems. All these are characterized by this focal loss of structure, collagen change in the tendon. These areas generally tend to have poor vascularity, so we have difficulty getting cells in there, low stem cell proliferation. Healing is ineffective and disorganized. And as I mentioned before, you get this chronic injury repair cycle that really never resolves. In terms of issues associated with this, there are intrinsic factors, we call them, things you can't really change, like anatomy and genetics and diabetes. And there are extrinsic factors that you can change, like overuse, training errors, and equipment problems. Traditionally, treatment looks at modifying extrinsic factors, physiotherapy, and injections. What about cortisone? Widely used, very extensively used. It has great initial benefits. It settles down inflammation. It's like an injectable Advil. 80% of tennis elbows improve after the first injection, but there's a 50% recurrence. And the problem is repeat injections cause tendon damage, does not help with healing, and you get increased tearing and weakness, which basically leads to propagation of the problem. Surgery is a last-ditch effort in many of these cases when other things haven't worked, but significant risks and very prolonged downtime. And overall, looking at many of the studies, the results are not much better than PRP. So what are we trying to achieve in tendonitis? Well, we want more blood supply. That's achieved with the platelets in angiogenesis. We want to activate myoblasts and fibroblasts to promote healing. We want to produce type 1 collagen and hyaluronic acid. We want to stimulate stem cell survival and proliferation, and we want to try and resolve the inflammatory process. And PRP, as we've seen with all those active little chemicals, seems to be ideal for all of this. And the results really look pretty good. Over the past few years, we've seen results like 80% for patellar tendonitis, nearly 90% for tennis elbow, 90% for Achilles tendonitis. And rotator cuff tendonitis, where we know surgical intervention has a really quite significant morbidity and downtime and a long recovery. For partial tearing and tendonitis, nearly 85% good to excellent results. And finally, acute muscle and tendon injury, something we see very commonly in the athletic population. Management is almost always non-surgical. So does PRP have a role in improving recovery? Well, it certainly seems to. For muscle tearing, we find it provides faster healing, less swelling, and less fibrosis. That translates into less muscle stiffness and reduced risk of re-injury once you get back to activity. Ankle sprains I see a lot of through the clinic, and they're all treated much the same, but they tend to be, even for mild sprains, you get this persistent stiffness, pain, swelling, which takes many months in some cases to go away. Ankle and PRP seems to offer a real option for faster recovery and less long-term problems with stiffness, pain, and swelling. Things like ligament sprains, MCL sprains in the knee, there are some good case reports and good basic science. Complete Achilles tendon tears, complete ACL tears, well, there's some good basic science again, but the research currently is still developing, and I haven't seen sort of any good studies looking at this. Overall, as you can see, PRP fits a really important niche in the practice, and I've adopted it for many patients. Obviously, I still do a lot of surgery, but there's increasing research support for PRP and musculoskeletal conditions. The advantages is it has a chance to improve both symptoms and promote healing. So you're really getting at things from both options. And it does offer a significant option to surgical intervention in patients who really aren't quite at that stage, or for many people who really say, you know what, I'm not ready for surgery. I don't want the risks. I don't want the downtime. Is there anything else you can offer? So thank you. And as Douglas said, if we've got any questions, let's see if we can answer them.
Thank you very much, Dr. Reed. I did place a message in the chat windows for all of our attendees. If you want to ask questions, please do so through the chat window, or you can ask through the questions option at the bottom. And we're going to do our best to get to as many questions as we can, recognizing that we're trying to also stay on schedule and get you folks on with your day. So we have a quick question here. I'm just going to try and read through it and see if we can distill it down to something that we can answer. We have, sorry folks, it's a bit of text here. So we have a patient or a person who's having some problems with some pain and feels that some weight can be related, which it definitely can be. This is knee pain. And I'm assuming that you've been told that you've got some arthritic change in the knee. And so the question is, does PRP help this sort of situation, Dr. Reed?
Yeah, I mean, obviously arthritis is a multi-pronged approach, and you start off with the easiest options. things like the physiotherapy, bracing we mentioned. You mentioned the possibility of weight loss, obviously always a difficult discussion and in many cases difficult to achieve, but very useful in the knee. I think I tell patients that if you lose 1 pound, that's 8 pounds less pressure off the knee. So even small changes can make a big difference. In terms of moving up through the treatment options, I think, obviously we talk about some medication and some supplements, but you do not want to be on anti-inflammatories chronically. So after that, you're looking at this gap between that sort of treatment and surgery. And, you may not want to consider surgery and you may not be appropriate for it. So something like PRP, looking at the research for knee arthritis, is a really good option. So I think, yes, I think in terms of, is it a treatment option for you? Yes, and I think as we noted, the results are really quite good.
All right, thanks, Dr. Reed. Another question here, is this useful for degenerative discs in the spine?
I have not used it in the spine. I mean, one of the issues obviously is access to the spine. This isn't something that I would generally think it couldn't be done blind or couldn't be done with ultrasound. Generally, injections into the spine would require X-ray guidance if you're trying to go into facet joints. I think I have read some injections into facet joints can be beneficial. They'd have to be multiple injections. In terms of injecting them into the disc, again, a possibility, but not that I've seen, not something I would do. Douglas, I don't know if anybody has been doing it. I think the injection process is a little more difficult, and I haven't seen a lot of good research on it.
Yeah, I'm the same, Steve. I haven't seen a lot on this injections into the spine. Certainly there's physicians across the world that are doing it. Slowly, publications are being released. I think that the consensus is that there is some help, but how much help, percentage of help, all that kind of information, I'm also not aware of. We don't inject into the spine at SEMI, as Dr. Reed alluded to. We do need special imaging equipment to do that. That's usually reserved for the hospital setting. Okay, the questions are rolling in, and I apologize, folks, but we're going to try and get to one more very quickly. Try and pick one that might be appealing to everybody. Oh, does PRP reduce inflammation in hip injuries? And the second part of that question is, does OHIP cover PRP treatments?
Okay, OHIP does not cover PRP treatments, and unfortunately most private insurance companies do not cover. I think I've encountered 1 or 2 insurance companies that somehow cover PRP, but generally insurance companies poor, and it's certainly not covered by OHIP. And is unlikely to. OHIP is underfunded and overused, and they're looking for things to delist rather than things to add to the list, even though it's obviously a minimally invasive option. And I think the other point of the question was for hip inflammation. Certainly, we've used PRP for hip arthritis and for hip injuries. I mean, depending on your age, if you've got hip arthritis, certainly there's a role for PRP, and that can be done under ultrasound guidance. The results overall, I don't think are as well studied or quite as good as for the knee, but certainly when we were doing the stem cell treatments, we found very good use from it. For hip injuries, for example, tendinitis or muscle tearing, yes, I think that would be something that would also be addressable with PRP.
Okay, thanks. And as I scan some of these other questions, there's a lot that center around the same theme. So I think what I'll do is just bundle them. There's many questions coming in about, can PRP help with this particular injury or that particular injury? The bottom line is PRP can be used for any joint or tendon or muscle or ligament injury that you may have. You may not necessarily be the best candidate for this type of intervention, depending on the severity of your problem, but any musculoskeletal tissue can be affected positively by PRP. So again, all these questions coming in, can it help with this injury, that injury? The answer is generally yes, but you'd have to be obviously we'd have to meet you, assess you, figure out if that's your best option. Okay, folks, again, I'm mindful of time. It's 9:24 and we have a few more speakers to go. Thanks, Dr. Reed. That was awesome, a great update. Our next speaker is Dr. Jennifer Gordon. Jennifer has been on our team at SAMI for a couple of years now. Dr. Gordon has an honors kinesiology degree from the University of Western Ontario. And when I first read that in a resume, as I was figuring out if she should join our team, that was actually something that caught my eye. Absolutely love that degree in medical practitioners who are in the sports medicine arena. Also, Jennifer went on to get her Master's of Health Science in Exercise and Sports Science from the University of Sydney. And this lady loves to travel. After obtaining her medical school degree at Trinity College in Dublin, Ireland, she then did her physical medicine and rehab specialty at University of Toronto. Member of College of Physicians and Surgeons in Canada and the Ontario Medical Association, Canadian Pain Society, Canadian Association of Physical Medicine Rehabilitation, and has completed specialized training in ultrasound guided injections by the Canadian Rheumatology Society. And that's, of course, one of the big skill sets that Dr. Gordon brings to SEMI. Dr. Gordon's specific interest is in musculoskeletal medicine, acute to chronic pain, and especially sports injuries. She has a competitive synchronized swimming background, and of course, lots of injuries in that sport. And she's got experience rehabbing all of those. All right, so without further ado, I'd like to give the mic over to Dr. Jennifer Gordon.
Okay, just give me one moment here. Slideshow. Play from start. Okay. Good morning, everyone. So thank you, Douglas. So I'm going to be discussing newer biological treatment. So one of the ones that we're using now at SEMI is called nSTRIDE, or APS, autologous protein solution. And then, so for the purpose of this talk, I'll be focusing on nSTRIDE. And then at the end, I'll touch on briefly Sanakin, which is very similar to nSTRIDE. And so the naming, sometimes you'll hear autologous protein solution, autologous cytokine rich serum, or autologous conditioned serum, and they're really all pretty much the same in terms of naming. So I'll talk about what is nSTRIDE APS. I'll briefly compare PRP, which was just touched on by Dr. Reed. I'll talk about the mechanism of action, the actual procedure, and then also the risk benefits and uses of this product, and then again, other products of interest. So just briefly, with osteoarthritis, it's the most frequent type of arthritis and commonly affects the knee joint. In the normal joint, cartilage provides cushioning between bones, and so as wear and tear occurs, the cartilage layer can become thinner or frayed, resulting in knee pain. And as I'm sure a lot of you may know, osteoarthritis does negatively impact quality of life through pain, poor mobility, as well as decreased function. So what is nSTRIDE APS? So in osteoarthritis of the knee, there's inflammatory cytokines, so bad proteins that outnumber anti-inflammatory cytokines, the good proteins, resulting in knee pain and cartilage degeneration or an imbalance. And I'll touch on this a bit more a bit later. So with nSTRIDE APS, it introduces high levels of the good proteins that are designed to overwhelm and block the bad proteins. And so there have been studies that have shown that nSTRIDE decreases pain, slows cartilage degeneration, unlike other traditional therapies. So when comparing nSTRIDE APS versus PRP, so both of them are autologous solutions in that they're derived from the body's own tissue or blood. nSTRIDE APS contains a high concentration of already activated and released anti-inflammatory cytokines and growth factors through activation of blood cells. So I'll discuss this in a bit more detail. So essentially, you withdraw the blood, and then through activation, you get higher levels of these good cytokines that can affect inflammation. Versus PRP, which is a simple blood plasma. It doesn't have already activated cytokines, and it's only after injection into the inflamed tissue that the blood cells receive an impulse to release the cytokines. And with PRP, it is quite variable in terms of, you know, how many of these cytokines are released. With APS or autologous conditioned serum, again, so this is just a pictorial just showing, so with the, sorry, I wish I had a pointer, but in terms of the, oh, here we go. So in terms of the medical device, it contains these glass beads, and so the glass beads essentially activate these cytokines, and then in doing so, you have the number ranges from 5 to 15 times more of these good proteins and growth factors. And then this is just a pictorial of PRP, where the blood is collected, is separated, and then it's injected into the tissue, and then only then, so once the cells meet the inflamed tissue, that they begin to produce and release the cytokines. So just a bit more into the mechanism of action of the autologous conditioned serum. So our body controls inflammation via special messengers, so via proteins or cytokines. These messengers dock onto corresponding receptors via lock and key mechanism in the joint and transmit their message or to trigger inflammation or stop inflammation. So in osteoarthritis, there's an imbalance of the body's proteins, which with the damaging interleukin-1 causing damage, inflammation, and pain. And so the natural antagonist of IL-1 is interleukin-1 receptor antagonist. So this, we also refer to this as osteoarthritis inhibiting protein or anti-inflammatory protein, or the good protein. So with nSTRIDE EPS, it contains increased concentration of this IL-1RA, as well as important growth factors from the patient's own blood. And so this osteoarthritis inhibiting IL-1RA occupies specific receptors on cartilage and synovial membrane cells in the joint. So it essentially pushes out the damaging protein and thus preventing access. And so this natural antagonist, or IL-1RA, has a pronounced anti-inflammatory effect and supports regeneration of the damaged tissue along with growth factors. So, and therefore balance is restored and inflammation subsides. So in terms of the actual procedure, blood is withdrawn, usually about 10 cc's, just as in usual blood draw. And then it's transferred into a medical device or cannula. It's then centrifuged or spun down, separated, so that you take the autologous conditioned serum, and then it's injected into the joint or desired location. And usually this process, takes around 30 to 40 minutes, and usually you're in and out within the hour or so, I believe. In terms of benefits, so it's a natural anti-inflammatory, thereby reducing pain. It inhibits cartilage degeneration, accelerates regeneration of damaged tissues, and then in doing so, you can also prevent or delay these surgical procedures that were discussed by Dr. Reed. There's very few side effects, so it's safe. There's no additives. Again, it's an autologous solution from your own body. The therapy duration or number of treatments is pretty much unrestricted, although with nSTRIDE, they found that you really only need one injection, which can last up to about a year on average. But technically you could do more. Whereas with PRP, usually you do need at least 2 or 3 in the short term to get the desired effect. And it's quite quick and easy to administer. And then in terms of risks and side effects, the same as with any procedure. So there's very small risk of infection, bleeding, a nerve injury, allergic inflammatory reaction. And you can have pain and swelling for the first few days, but eventually that subsides. And then also there's always a chance that it doesn't work. And then in terms of potential uses, most of the research we have is on osteoarthritis. You know, potentially there could be a use in osteoarthritis of the spine. However, as we discussed, you know, it is a lot more difficult to reach or access. And then also for any type of tendinopathy, muscle fiber tears. And then there's also ongoing research in terms of other procedures like cosmetic or dental. And then just as I discussed, the other product, apart from nSTRIDE, that we know of is Sanakin, and it's similar in mechanism to nSTRIDE in that it is an autologous conditioned serum, but it does require at least 3 hours of incubation, so making the procedure longer. It does seem to be a lower cost than nSTRIDE, but may require more injections, and it's not yet approved by Health Canada, but I hear very soon. And then this is just some preliminary research from Sanakin, an observational study of 100 patients, mean age of 60 years. They did have multiple injections though, requiring 3 hours of incubation. And there's you know, quite a significant change in the VAS score, which is the visual analog scale. So in summary, autologous conditioned serum causes the creation of anti-inflammatory and regenerative serum based on the activation and proliferation of the body's own cytokines. This supports the natural healing process in the body, thereby accelerating regeneration. And these anti-inflammatory cytokines thus alleviate pain, inhibit inflammation, and protect the cartilage, all while being well tolerated. Thank you.
Okay, thank you very much, Dr. Gordon. We are continuing to try and address questions, and they are rolling in. I'm going to just have a look at the chat screen and see what we can find here. And as your questions are rolling in, we've been trying to answer them as well. Dr. Reed's done a few, and I've been trying as well. So thank you for those. Okay, we have one here. Hello, are both nSTRIDE and PRP done at SEMI? Well, I can answer that. That is absolutely yes. And this part is an excellent question. How is it determined which of the two is more appropriate in a specific case, i.e. for a meniscus tear? Dr. Gordon?
You know, that's a good question. Again, you know, these treatments are a little newer. And so with a meniscal tear, so essentially with both procedures, you are technically hoping for a regeneration of the tissue. I guess it also depends on pain. Is that right, Douglas? So in with nSTRIDE, the theory is that it can provide more of a anti-inflammatory effect, thereby reducing pain. So that, you know, there's quite a few factors to be taken into account. You know, the number of treatments is more with PRP than potentially with nSTRIDE or APS. I'm trying to think of a few other factors to consider. Do you have any other thoughts?
Well, I think you hit the nail on the head. I think we're generally using nSTRIDE as a second line injection option, more for arthritic related pain. We're not injecting nSTRIDE into tendons, at least not yet. PRP we reserve for tendons. And nSTRIDE, for me at least, has been a second line option when PRP hasn't helped with a joint related painful condition, usually being osteoarthritis is where we use it. And so also this person's asking details about what to expect after the procedure.
So in terms of PRP and nSTRIDE APS, a pretty similar course. In terms of the injection itself, you can have some initial pain and swelling the first couple days. So we usually ask the patient to avoid any significant weight bearing. And then it's gradual from there. So, you know, within the next 2 weeks, you know, we generally we generally recommend increasing the your activity level, and we also provide rehab protocols in terms of the therapy thereafter. In terms of what to expect, so yes, there, you can have some pain and swelling, but that does diminish over the course of the next couple days. So really, it's it's not a significant procedure by any means. Basically.
Yeah, it's pretty easily tolerated. Dr. Reed, can you comment on the risks associated with injection therapy?
In terms of major risks, I mean, I think the infection or something like that. I think no more risk than taking blood or injecting joints, which we do all the time, as long as it's done under sterile conditions, which obviously it is. I think you're looking at 1 in 10,000 sort of risk. The main risks I tell patients about are some post-injection pain and stiffness. And normally this is mild. 1 in perhaps, I would say, from my experience, maybe 1 in 30 patients will have a more vigorous reaction and can be quite sore. And I'll sometimes, if people haven't had it before, I'll give a couple of stronger pain pills just in case, because you can't take anti-inflammatories. Apart from that, a little bit of bruising from the injection site. So overall, I think the risks and complications, especially when you're comparing it to something like surgery, are really, really minimal, and in most cases don't interfere. I think it's fair to say that the pain from tendon injections, like tennis elbow, is going to be much worse than a joint injection. Patients who inject knee arthritis, I call them all the next day, and very few of them have anything more than some mild swelling. People who've had a tendon injection, shoulder, patella tendonitis, elbow tendonitis, that can really be quite sore, and I think that's something to bear in mind, because you're really recreating the original injury. But in terms of overall complications that aren't expected or aren't part of the healing process, I think they're few and far between.
Yeah, I would tend to agree there. Only infection is what we want to emphasize with our patients. We always try and review that, as Dr. Reed alluded to, really low risk of infection. Any needle in the body is going to risk infection. It's a 1 in 10,000 risk or less. So not a zero risk, but a very low risk. Otherwise, post-injection pain can occur for days to sometimes weeks. It's usually easily managed with some extra strength Tylenol for a few days. And we get people rolling right away with a therapy program, very active in the recovery. So all in all, these are very safe procedures. Okay, thank you very much for those questions. Again, we'll keep trying to answer them. And I am last on the list today. There was a question that came in that I purposely ignored because I knew we were going to get to it, and that is the big question of the day: will stem cells ever be offered again in Canada for musculoskeletal problems? And so that's what I wanted to talk about today. I also want to give special thanks to MD Biologics and Murray Downs specifically, who supply us with lots of our PRP kits and products. And so Murray's generously sponsored today's event. So thank you, Murray. Okay, so stem cells and musculoskeletal medicine. And this is a hot topic, frustrating topic. And by the end of this, hopefully I've conveyed to you an update and what's going on here and perhaps a little bit of the frustration involved. So the timeline, SEMI began offering these procedures in 2012, and we did probably around 700 of them between then and May of 2019. And then, or rather, we used them in arthritis, we used them in tendon tears and meniscal tears. And then in May 2019, Health Canada came out with a position, made it public, and basically enforced all centers offering this therapy had to stop. So this is quite a sudden decision. And that was, as I said, in May of 19. And so the idea here is, who are the stakeholders? Number one, of course, are Canadian patients. Thousands of Canadian patients, when we were offering them all across the country, did receive these injections. So they're the number one stakeholder. We're trying to provide a way for patients to avoid surgery or delay surgery on things. And the injection class, including PRP, nSTRIDE, Sanakin, when eventually we may start offering it, and stem cells, this whole injection category, as has been explained, is really this middle ground between conservative care, such as therapy, bracing, orthotics, some medications, and the more aggressive and invasive option of surgery. And these injections really do fill that void very nicely. So we felt stem cells were a complement to that, to that effort. Doctors, of course, are stakeholders. We want to help our patients. There's nothing more frustrating than sitting in front of a patient who has a problem and you're scratching your head what to do for them, especially when they're in pain. And we found that these procedures helped a lot of pain. So that's one of the reasons why we like them. Health Canada, of course, is a stakeholder. They do have a mandate to protect the public. No one's going to disagree with that. That is for sure. Academics and ethicists have a role in this and a say in this. There are ethical concerns. Are we providing treatments to patients that aren't proven or that are unsafe? Unsafe being the big one. And so, yes, there's always ethics involved in how we as physicians advise our patients. Scientists who are laboratory scientists who are researching stem cells, some I think feel that the train's moving too fast with incorporating these treatments into real life patients. And of course, media. Media always has a stake in any big story. And certainly 2 years ago, some of you may have read the stories. There was a lot of media generated over this topic. Bad press, unlicensed clinics offering unsafe procedures. It went on and on and on. And, personally, I'm a little bit jaded with the media, especially in this area. I was interviewed by CBC for an hour a couple of years ago around this very topic. Not 1 second of my interview was published, offering a balanced view on what was going on. So yes, media's in there. They're generating clicks and ad revenues to the best of their ability, and they are a stakeholder in this as well. So let's talk about the concerns, because this is what has been published on the Health Canada website. The idea here is claims that cell therapies are safe and effective must be based on evidence from well-controlled clinical studies from the Health Canada policy position paper. Question then, of course, is, at this time, do we have this evidence? One of the big problems in this space is lumping all stem cell procedures into one category. Many different branches of medicine are trying to see if stem cell therapy helps. So we've got our area of medicine, which is musculoskeletal medicine. We have cancer, we have heart disease, we have neurodegenerative disorders, including Parkinson's, et cetera, multiple sclerosis. So every branch of medicine is trying to do something with stem cells. In my opinion, it really is the way of the future. Our challenge, of course, is bringing the future to the now to try and offer these procedures. But the challenge in some way is that all of these areas of medicine are lumped into one. Nothing could be further from the truth. Some of these areas of medicine are very well developed from a research perspective, including musculoskeletal medicine. And some are quite new. Back to the ethics. There are practitioners offering stem cells for everything under the sun. Totally agree. That is unethical because there isn't a lot of support yet for some of these applications. But in the area of musculoskeletal medicine, there is a strong research base. So the number one question on any physician's mind when we advise something to our patients, and of course, the number one question on your minds as patients should be, is it safe? And this is something that we are very concerned about when we advise our patients. Is it safe? So we want to go through 4 areas of potential safety problems that Health Canada has identified and deal with them very quickly, one at a time. They are: 1, the potential introduction of bacteria or viruses into either the stem cell sample or the patient. i.e. causing an infection. Number two, cross-contamination. If we use instruments that need to be re-sterilized, are we risking the patient by doing so? Number three, are there risks resulting from the processing activities of the stem cells? Do we add chemicals to them? Do we somehow process them in a way that could add risk? And number four, are we stimulating unwanted reactions in the body? And these include unwanted immune reactions, and these include tumor growth. So let's deal with each one of these. One, the potential introduction of bacteria viruses. Very simply, there have been no reports ever of any viruses or bacteria being introduced to any processed sample of stem cells used in musculoskeletal medicine. No reports. Does that mean along the way somewhere in the world it may have happened? Yes, and it wasn't reported. But a review of the literature to date, and I've tried my very best in this, can't find any reports. Methods of production with stem cell therapy in our field use closed systems done at the bedside. We do take the stem cells out of the body, we put them in a container, we may process them in ways in a centrifuge, clean them and concentrate them, but at no time have we ever had any reports of introducing bacteria or viruses into these samples. As I said earlier, there is a 1 in 10,000 risk that we may infect a patient when we pass a needle through their skin, but that is not specific to a stem cell procedure. That could be any injection, including a flu shot or a COVID shot or any immunization. In conclusion then, with number one, there is a valid theoretical risk, but not one that has ever been reported. And in light of current approaches, these stem cell samples, the risk is virtually zero. Two, between patient cross-contamination. For example, if equipment is not properly sterilized. So for instance, in the hospital, when Dr. Reed, for instance, operates on patients, many of the instruments he uses are reused instruments. In other words, they are sterilized to be used again and again and again. In dentist's office, this happens every day, and in physicians' offices. Same thing. All over the world, we reuse instruments every day in medical and dental practice with modern sterilizing techniques that are safe and very effective. So this technique, these approaches have been around for years. Preventing infection, again, remains our number one priority in clinical medicine. Sterilization techniques are modern and very effective. And again, risk of infecting a patient using reused instruments, as long as these sterilization policies and procedures are followed, again, is virtually zero. This is a picture of a couple of sterilization machines. This is a steam sterilizer. That's the one we use at SEMI. This blasts hot steam into the instrument chamber, kills everything. And this is a X-ray chamber used to sterilize certain things. Number three, are the risks resulting from processing the stem cell sample? Do we, in other words, put chemicals into the sample, anything that might affect the patient? So when we're harvesting stem cells, those that have had these procedures know we have to use some local anesthetic to freeze the area so that we can pull out the sample we're looking for. We either pull it out from fat or we pull it out from bone marrow. So we do have to freeze things so it's as comfortable as possible for our patients. So the stem cell sample may contain some anesthetic, and we want to wash that out. And we do. We wash it out with salt water. We add nothing more to the stem cell mix. Simply salt water. It's a balanced solution that is compatible with the chemistry in our blood. There is no risk to using salt water. We wash the samples, and that's it. So again, a valid theoretical risk if we were adding chemicals and various toxins and reagents, but we're not. We're simply removing the local anesthetic that invariably gets into the sample because we have to freeze the patient. But remember, that local anesthetic's already in the patient anyway, which we use to freeze them. So by removing it from the sample, we're simply cleaning up that concentrated anesthetic in the sample before we put it back in. Again, no risk. So that's safety. And we have a process in stem cells that we call expansion. Expansion means we grow them. So we take out the sample, and over several days to several weeks, we expand them or grow them in the laboratory. Why do we do that? Some people think more is better. In the area of stem cells, it's been researched, is a higher quality or quantity sample of stem cells more effective for the patient. To get a higher quantity sample, some people have tried to grow them or expand them. So we do know one thing, that expanding stem cells changes or can change the DNA of that stem cell. And as you know, the DNA is the genetic code, and the DNA can tell the cell to reproduce in a way that's cancerous or tumor growth. So the risk of tumor growth, it increases if we expand the cells. We have never expanded cells at the bedside with our bedside stem cell procedures. And so this risk has never been reported in a non-expanded stem cell procedure. And then that's where we're into number 4, the stimulation of unwanted reactions, such as tumor formation, we just talked about, and immune reactions where the body attacks itself. Different diseases, the body attacks itself. We don't know why. Diabetes type 1 is an example. Rheumatoid arthritis is another example. And there are many more. So do we induce the body's tendency to want to attack itself using these procedures? Again, no report has ever come out that has stated that this is actually something that has happened. You have to remember, these are your stem cells. You simply take them out and put them back in. So the chances of having a reaction to these cells is, again, next to 0. So let's talk about evidence and what, drilling down a little bit more on what Health Canada is looking for. This is called an evidence pyramid. We have 5 levels of evidence basically in science and medicine. At the bottom, we have the weakest level of evidence, which is basically expert opinion, and opinions derived from dealing with patients, basically, case-based reasoning. This level of evidence is certainly important. You see 1,000 cases over your career, you're going to generally develop some opinions that are based on observations over the years that I don't think should be easily discounted, but it's not considered strong scientific evidence. Level 4, case series, where we compare patient, or rather don't compare, but we analyze patients who are treated with some sort of intervention over time, and we ask them questions, maybe do some follow-up tests, find out how they did. It's a case series of one group of patients. Level 3, we're getting higher, we're doing case-controlled studies. So here we compare different treatment groups, one to the other, and we find out if one did better than the other. This is a case-controlled level. Level 2 are cohort studies. This is where over long, lengthy periods of time, these are otherwise called longitudinal studies, we analyze reactions and outcomes of patients who are exposed to a certain treatment. Some of these longitudinal studies literally can be 30 years or more. And level 1, the gold standard remains randomized controlled trials. This is where we have at least 2 treatment groups, and one group gets treatment A, one group gets treatment B. We randomize patients to these groups, meaning it's a random assignment of the patient to a treatment group. And blinded means that the patient does not know what treatment he or she received. So in other words, there can be no bias in their assessment of the treatment. Level 1 remains the gold standard. Back to safety. We have plenty of level 1 evidence. In other words, the highest quality evidence you can obtain, that stem cell procedures done at the bedside are safe. This was summarized in a paper that a working group that I am part of formed, and I won't take any credit for this particular summary. This is done by Dr. Robert Burnham, an Alberta physician who's a colleague of mine, and this was done to present evidence to Health Canada regarding the state of the art regarding stem cells. Level 1 evidence. So it is safe, and therefore number 1 thing in our minds as physicians, and probably yours as patients, is it safe? The answer is absolutely. But is it effective? Does it help people? Well, we have level 3 evidence for the ability for stem cell procedures to help and objectively evaluate their effectiveness. And back to our pyramid, This is in this area. So in other words, the evidence is of moderate strength. It's not down here at the opinion level. It's not up here at the randomized, consistently randomized controlled study level. Are there randomized controlled trials in stem cell research to assess efficacy? The answer is yes. There's just not enough of them yet to place the evidence up into level 1 on a consistent basis. So Health Canada's solution to all of this is a clinical trial application. This is a process where anybody interested in research must submit a requisition or a research proposal to Health Canada. And Health Canada has to approve the proposal before they will allow the research to proceed. And so this is a clinical trial application. Currently in Canada, this is the only way any patient can obtain a stem cell transplant. Has to be done with a physician or a group that has been approved through a clinical trial application. And according to Health Canada, should a product be demonstrated to be safe and effective through authorized clinical trials, Health Canada takes steps to approve it. Excuse me. Big word there, as you see underlined, is authorized. Thus far, Health Canada has chosen to conclude that all the international research done to date on this topic is not acceptable. So they want new authorized trials to be approved by them in the way that they want the trial done. And then they will allow patients to be enrolled in these studies. And that's how patients now are going to be able to get these procedures. Right now, there's one doctor in Canada that has successfully obtained a clinical trial application. He's in Kelowna, BC. No other clinical trial applications have yet been approved. I will say it's an incredibly onerous process to get a CTA, very costly, takes a lot of time, and adds a very serious layer of administration and more responsibility on the physician administering the trial. These trials are done by pharmaceutical companies wanting to bring a drug to Canada and launch a drug on the market in Canada. They are exactly the same type of trial. And unfortunately, the average community physician just doesn't have a research department to be able to do this. So how many doctors actually end up going for these CTAs remains to be seen. This is a summary from a letter issued by Health Canada, May 19, 2021, where they again reaffirmed that despite the many international studies, they're not happy with these studies. Read their design and conclusions. Health Canada requires more studies to be done in Canada with protocols approved by Health Canada through the clinical trial application process. Patients can obtain these procedures if they are able to enroll in a study. As I said, they're quite costly and time-consuming and very demanding to the point where pharmaceutical companies who have to do these studies have full research departments to do them. And again, we will see if any doctors take on this immense task. Right now, I'm part of a group who has been engaging Health Canada, and now we're at the stage where, as a group, we're discussing whether or not this is a direction that we actually want or are able to take. So that is the end of my presentation. And we now want to open up the questions again. We're going to try and take some more questions. So just bear with me as I try and navigate and unshare my screen. Just one moment. Okay. We're back. Okay, so trying to get to more of these questions.
Yeah, we've been trying to just answer as many of them as possible by text. So
thank you, Dr. B. That's why I'm not seeing many new questions.
There aren't too many. There's just one left about the slides being mailed out or something.
Actually, we haven't really thought about that, but we certainly can. I'm not sure the logistics involved in that with emailing the whole database that signed up for this, but we can certainly look into that.
Is it being recorded as a like on the SEMI site as a
Yes. So what will be done, what we have done in the past, is we do record it and upload it to the website. So the whole presentation will be there. And so therefore the email option, thanks for that reminder, Dr. Reed. Yeah, the email option really won't be needed. We will upload it to the website. Okay, any further questions on anything today, ladies and gentlemen? I see that we tried to answer most of them. Anything
there's just one that came up there, Dougie, about is stem cell treatment more effective than PRP?
Excellent question. And to date, there hasn't been really a lot of good head-to-head comparisons between stem cells and PRP use. Over the course of the 7 years, we offered them at SEMI, and as I said, we probably did about 700. Our impression was that these procedures worked very well in varying amounts, meaning about 80% of people did achieve some success, ranging from mild reductions in pain all the way up to a miracle as far as reductions in pain, where people literally felt, wow, this is amazing, and you've given me a new lease on life. PRP actually looks to be doing the same once we changed our PRP protocols to more PRP and multiple injections of PRP. We're seeing a very similar type of response. Now, this is all very rough and very observational, has not been assessed specifically with a good, well-formed research project. But our impression is that the PRP higher dose, multiple dose options are doing at least, well, almost, if not matching, the stem cell reduction in pain. What we don't know yet is how long it's going to last. We were seeing multi-year results with the stem cell procedures in many patients. I'm not sure what we're going to be seeing with the PRP in terms of multi-year results. Probably we're seeing a year, as Dr. Reed alluded to earlier, maybe 2 with PRP. Though I have seen patients literally 5 years later after PRP still feeling much better. So that's up in the air right now. There is a question, I'm pleased with, or maybe a statement from Shirley. I'm pleased with the results I've had with stem cell injection. Even though my MRI showed my tear got worse, my pain is well under control. I now need to do the other knee and would prefer stem cell. Interesting comments. And briefly, let's talk about imaging and stem cells. Imaging a meniscus tear, for instance, with MRI is very difficult to know whether or not you've helped the meniscus. You do need a special MRI machine called a quantitative MRI machine, which specifically images the tissue in a way that allows us to assess in more detail whether we've actually healed that tissue. The MRIs we now use in Canada are diagnostic MRIs, and it's difficult to use them to assess actual healing in soft tissue injuries. I'm a little leery when I see reports after injections comparing, because they're often hard to interpret. Dr. Reed, Dr. Gordon, any comments on those ideas?
Yeah, I would agree. The current, I would tell patients, even surgical patients who've undergone a meniscus repair, you can follow them up clinically, but I say, well, can you do an MRI to see whether it's healed? And you cannot. It looks exactly the same, whether it's not healed, whether it's healing, or whether it hasn't healed. So the only way to do it is to obviously go in and do further surgery, which is not something we do. So yeah, it's not great. MRI is not 100% at looking at the morphology or the details of the tear. In addition, there are lots of tear types that don't actually represent tears. They just represent a natural degeneration within the meniscus. And that's one of the things we talked about in terms of arthroscopy for arthritis, in terms where you've got a meniscus tear in the background of arthritis. The tearing is probably not the important factor. The factor is the degeneration and arthritic change. And that's obviously way more amenable to PRP than surgery.
Yeah, I mean, those are great comments. And back to the idea of a tear in the context of arthritis, I also advise patients the same way. I discourage people from getting too focused on a meniscal tear when it's present in the context of an arthritic joint. So to answer that question about, you know, what sort of works with these things, as Dr. Reed just said, we do often want to try an injection option for these patients because they're really not surgical candidates. Okay, well, that actually looks like the chat questions. Yeah, so I think that's it, folks. I really want to thank you all for joining us on your Saturday morning. We haven't gone too much over, so please enjoy your day and your weekend. And June 2nd is coming. Let's keep our fingers crossed that we're going to get some more freedom this coming week. Hopefully you're getting your vaccinations, and many of you have had at least one. Fortunately, I had my second one yesterday, and I think we're starting to move through things a little quicker now. So hopefully that's the case for you as well. Have a wonderful weekend. And if you have any questions further, need any help, want to consult with us about any of these things, please feel free to call the clinic. 416-223-SEMI, 416-223-SEMI. Thanks again. Everyone have a good day.
Thank you. Thanks, guys.